Yeah, the one point I wanted to make, Shivani presented very well, and unfortunately she's left the hall. But ocular surface disease is something that is increasingly being recognized, and these situations are best suited for mix. We should be avoiding any surface surgery in these kind of individuals, especially if they are mild to moderate. The lesser number of medications for them, the better. No medications, the best.
Best, that's true. Now we'll take up with her talk. She's ready with the talk. Dr. Deepthi.
So, good afternoon, everybody. Are you able to hear me? So, I'm Dr. Deepthi, and I'll be presenting on congenital glaucoma management for the beginners. The main reason to present this is I know most of us are apprehensive to do a case of congenital glaucoma, but it is very important because the prevalence is quite high. So the incidence in Western countries is 1 in 10,000, and in the combined states of Andhra Pradesh and Telangana, it is 1 in 3,300.
Can we have the timer, please?
The involvement is usually bilateral, and it accounts for 4% of childhood blindness. The most of the cases are sporadic, with 10 to 40% being familial and autosomal recessive pattern with CYP1B1 gene involvement, which is involved in the metabolism of an endogenous substrate required for normal trabecular meshwork development. So classification is congenital, where the symptoms are at or before birth up to the age of 3 months, infantile from 3 months to 3 years, and juvenile from 3 years to teenagers. And developmental pattern, primary developmental and secondary developmental. Secondary developmental being the trabecular meshwork damage occurring due to maldevelopment of some other portion of the eye, as occurs in the pupillary block eyes with the microspherophakia and dislocated lens. So this is the childhood glaucoma research network, where they have divided both primary congenital glaucoma, juvenile open angle, and the acquired non-acquired systemic and ocular anomalies as well. So we will be mainly concentrating on the primary congenital glaucoma. So the triad of epiphora, photophobia and blepharospasm, the classical triad, where the raised intraocular pressure causes corneal epithelial edema initially, causing irritation of the trigeminal nerve, causing photophobia and blepharospasm. Increased IOP also causes globe distension, as the sclera and collagen are still pliable, leading to megalocornea and ophthalmus. So the corneal enlargement occurs up to the age of 3 years, but the sclera can be deformable until the age of approximately 10 years. So pre-existing megalocornea with elevated IOP, further elevated IOP can cause a break in Descemet's membrane, causing gain into the stroma and aqueous and corneal hydrops. So this is a 3-month-old child who presented to me with history of whitening of the black portion of the eye from the past 2 weeks. The other clinical features include HAPS striae. So they are typically horizontal and linear, where they occur centrally, and they are parallel and curvilinear when they are in the periphery. So the HAPS striae are formed when the new Descemet membrane is laid down due to the curled edges, where they entrap the keratocytes, stimulating proliferation. So optic disc cupping, the cupping is rapid and occurs in infants. It tends to enlarge circumferentially with glaucoma progression, and it is reversible with normalization of the intraocular pressure. So there's a minimal laminar connective tissue, and there is no immediate loss of axons, and it is reversible. So the mimickers of primary congenital glaucoma, megalocornea. So the diameter can be more than 30 millimeters of mercury, but the increase in anterior chamber only occurs with a normal vitreous chamber. Along with the IOP is generally normal and the disc is healthy. Coming to birth trauma, the HAPS striae are generally vertical or oblique, and the disc is healthy and IOP is normal. Conservative management. In CHED, the corneal diameter is normal, HAPS striae are absent, corneal thickness is very thick, and axial length is normal, and IOP is also usually normal, and if high, it is due to the increased corneal thickness. So examination under anesthesia very important. Check the IOP before any contact procedure, 3 to 5 minutes after the intubation, as the adrenergic stimulation caused by intubation can persist for 3 to 5 minutes. So anesthetic agents like ketamine and succinylcholine increase the intraocular pressure, and mild decrease occurs with midazolam and sevoflurane. So gonioscopy evaluation of the angle is very essential for the diagnosis of the developmental glaucomas. This can be done with a Copace lens, or it can also be done with a 4-mirror gonio lens. So in this picture you can see I have taken picture with the 4-mirror gonio lens, where you can see both the disc cupping as well as the angle structures. Examination of the anterior segment is very important. Why I am stressing is it is not just about the surgery, but everything needs to be evaluated before you go into a surgery. So corneal examination, anterior chamber, iris details and lens details have to be noted. Posterior segment examination, indirect ophthalmoscopy, and a cup disc ratio of more than 0.3 and more than 0.5 in older children is significant. Asymmetric cupping is also significant. An A scan has to be done and a B scan. If the cornea is grade 3 to grade 4, where you cannot examine the disc or the posterior segment, it is essential to do a B scan to rule out any other posterior segment pathologies. UBM also has to be done. So these are the following features. There can be thinner iris, larger anterior chamber angle, larger zonular length and thinner serially body. Corneal assessment, the horizontal corneal diameter more than 11 millimeters at newborn is significant. Pachymetry, megalocornea, the pachy is normal. In ophthalmos it is less, and CHED the pachymetry is increased. Refraction is essential to look into the refractive error and also the astigmatic change due to the HAP striae. Medical management, temporary control of IOP while waiting for surgery in congenital glaucoma. Beta blockers and carbonate anhydrous inhibitors can be given with caution, along with oral Dimox 15 millimeters per kg body weight. And it is surgery is the definitive management in congenital glaucoma. Surgical options are as follows. So in goniotomy, with the help of a after placing a direct gonio lens, a 24 gauge needle attached to a 2 cc syringe is placed. In interest of time, I would like to go into combined trabeculotomy and trabeculectomy. So this is the 3-month-old child who presented to me with enlarged cornea and haze in the right eye. So sorry for that. So for the surgery per se, limbal-based fornix-based conjunctival incision was made. Limbal-based incision, and the conjunctiva is dissected with great precision. It is very important because the child has a long way to go and might require several surgeries. So after careful dissection of the conjunctiva, coming to the tenons is generally very thick in them, and the texture of the tissue is quite different in these patients. Later, a careful conjunctival cautery is done, and a scleral flap of 3 into 3 millimeters, half thickness to 1/3 thickness is made, and the scleral the flap is raised, triangular flap, and once the flap is raised, a pre-placed suture has been placed to the flap, and an incision is made at the junction of the gray zone and the white zone, and you can see that the fluid is egressing and a small bleed is seen. It indicates that we are within the Schlemm's canal. Then a trabeculotome is inserted, and it is inserted into the anterior chamber, likewise on the other side. So around 100 to 120 degrees of trabeculotomy is performed. Later, a scleral block is dissected, and after the scleral block, peripheral iridectomy is done, and the triangular scleral flap is closed with one 10-0 nylon suture, and the conjunctiva is closed with continuous suture 8-0 vicryl. So this is the baby 1 month post-op, and 3 months post-op. You can see that the corneal haze is reduced just with a small corneal haze. So it is the management starts here actually. So the corneal scar, you have to do a mydriasis, surgical iridectomy or keratoplasty. For refractive error, myopia, astigmatism, you have to give prescribed glasses, and for amblyopia, glasses and patching has to be done. So emotional and financial rehabilitation is very important for the family as well. It requires a lifelong follow-up, family screening and genetic counseling. Thank you so much.